Welcome to the third part of this lecture on cardiac examination. Familiarize the sequence of the cardiac examination. First, in supine position with the head elevated at 30 degrees. Inspect and palpate the precordium, right ventricle, left ventricle, and apical impulse. Second position will be at left lateral decubitus position. The examiner will palpate the precordium and listen at the apex with the bell of the stethoscope. Third position in supine position with the head elevated at 30 degrees, auscultating the 6 listening areas with the diaphragm. Next position, sitting, leaning forward after full exhalation, and listen down the left sternal border and at the apex with the diaphragm. Let's start the details of the examination. First, carefully inspect the anterior chest and noting for the PMI by shining a tangential light across the chest wall to appreciate the apex. When shining a light, position the pen light obliquely at different positions so that you create a small shadow produced by the forward thrust of the PMI. If the apex is identified, palpate the PMI to confirm its characteristics. Use finger pads in palpating the PMI. The PMI may be tapping, which is normal. It could be sustained, which suggests left ventricular hypertrophy, or diffuse, which suggests congestive heart failure or cardiomyopathy. Locate the PMI by interspace and the distance in centimeters from the mid-sternal line, which is 7 to 9 centimeters. Assess the amplitude, diameter, and duration. In the supine patient, it is usually measures less than 2.5 centimeters, about the size of a quarter, and occupies only one interspace. Check for heaves and thrills and know how to differentiate them at these locations. To palpate heaves and lifts, use your palm and/or hold your finger pads flat and obliquely against the chest. Heaves and lifts are sustained impulses that lift your fingers. For thrills, press the ball of your hand, which is the padded area of your palm near the wrist, firmly on the chest to check for a buzzing or vibratory sensation caused by underlying turbulent flow. If present, auscultate the area for murmurs. Now, let's watch this video.
Your examination of the heart will consist of inspection, palpation, and auscultation. Let's begin with inspection and palpation.
I'm going to look at your chest.
To examine the heart, stand at the patient's right side. Have the patient remain supine with the upper body raised to about 30 degrees. First, inspect the anterior chest, noting any heaves or lifts. None are observed here. Careful inspection may also reveal the location of the apical impulse. When visible, the apical impulse is normally seen in the left fifth interspace at or medial to the midclavicular line. Later in the examination, you will palpate to more clearly identify the apical impulse. Following inspection, proceed with general palpation of the chest wall. First, palpate for impulses using your finger pads. Hold them flat or obliquely on the body surface as you palpate in the right and left second interspaces, along the left sternal border, and in the apical area. Ventricular impulses may heave or lift your fingers. Then check for thrills by pressing the ball of your hand firmly on the chest in these same locations. If subsequent auscultation reveals a loud murmur, go back and check for thrills over that area again. Next, identify the apical impulse. The apical impulse represents the brief early pulsation of the left ventricle as it moves anteriorly during contraction and touches the chest wall. Note that in most examinations, the apical impulse is the point of maximal impulse, or PMI. However, some pathologic conditions, an enlarged right ventricle, for example, may produce a pulsation that is more prominent than the apical impulse. Using the palmar surfaces of several fingers, then for finer assessments, your fingertips, followed by one finger alone, palpate to confirm the characteristics of the apical impulse. You will note its location, diameter, and amplitude. Identify the location of the apical impulse by the interspaces in which you feel it, and by its distance in centimeters from the mid-sternal line. If you experience difficulty in locating the apical impulse, ask the patient to roll onto his left lateral side.
Can you tip over on your left side, please?
That is, into the left lateral decubitus position. Palpate again using the palmar surfaces of several fingers. If you still cannot find the apical impulse, ask the patient to exhale fully and hold his breath for a few seconds.
Exhale fully for me and hold your breath for a few seconds.
Measure the diameter of the impulse in centimeters. Feel for the amplitude of the apical impulse. It is usually small and feels like a gentle tap. With experience, you will learn to feel the apical impulse in a high percentage of patients. However, obesity, a very muscular chest wall, or an increased anteroposterior diameter of the chest may make the apical impulse undetectable. Next, feel for a right ventricular impulse at the lower left sternal border and in the epigastric or subxiphoid area. While keeping one finger in the third interspace, place additional fingertips in the fourth and fifth interspaces. If the patient's chest has an increased anteroposterior diameter, palpate for the right ventricular impulse high in the epigastric area where it may be easier to feel.
Percussion is used to outline the borders of the heart. Starting with the left side of the chest, percuss from resonance toward cardiac dullness in the second, third, fourth, fifth, and possibly the sixth interspace. The normal values are as follows. In auscultating the heart, position the patient properly. Remember the slide in positioning the patient given early in the initial part of this third lecture. Auscultate at these 6 listening areas. First, place your stethoscope at the second right interspace area. Next, at the second left interspace. Third left interspace. Fourth left interspace lower sternal border. Fifth left interspace lower sternal border. And sixth at the apex. The pattern of auscultation could either be from the apex to the base or from base to apex. When auscultating, note the rate and rhythm. Normally, the rate is 60 to 100 beats per minute. The pattern is regular. Sinus arrhythmia might be normal in young adults and children, and it increases during inspiration and decreases during expiration. Identify S1 and S2. This is important because S1 is the start of systole and thus serves as the reference point for timing of all other cardiac sounds. Usually, you can identify S1 instantly because you hear a pair of sounds close together, lub-dub, and S1 is the first pair. S1 is louder than S2 at the apex. S1 coincides with the carotid artery pulse. The sound you hear as you feel each pulse is S1. And S1 coincides with the R wave if the person is on an ECG monitor. Assess S1 and S2 separately. S1 is the first heart sound and is caused by closure of the AV valves, and it signals the beginning of systole and is loudest at the apex. S2, which is your second heart sound, is associated with closure of the semilunar valves and is loudest at the base. What is splitting of S2? This is a normal phenomenon that occurs toward the end of inspiration. Volume of the right and left ventricular systole is just about equal, but this can be affected by respiration. To learn this, consider the phrase more to the right, less to the left. Closure of the aortic and pulmonic valves is nearly synchronous, and inspiration separates the timing of the closure of the two valves. So during inspiration, more volume is pushed to the vena cava, which increases the right ventricular volume. The increased volume prolongs right ventricular systole and delays the pulmonic valve closure, while on the left ventricle, during inspiration, more blood is sequestered in the lungs, resulting to lesser volume of blood in the left ventricle, allowing earlier closure of the aortic valve. And it will be heard as lub-tidup, lub-tidap, lub-tidap. Listen for extra heart sounds. Your S3 is the third heart sound. Normally, diastole is a silent event. However, in some conditions, ventricular filling creates vibrations that can be heard as S3. It occurs when the ventricles are resistant to filling during the early rapid filling phase. It occurs immediately after S2, when AV valves are open and atrial blood pours into the ventricles. S4 is the fourth heart sound. It occurs at the end of diastole, at pre-systole, when the ventricle is resistant to filling. The atria contract and push blood into a non-compliant ventricle, creating vibrations heard as S4, and it occurs just before S1. To review S3 and S4, go back to the first part of this lecture and see the illustration of the cardiac cycle. Listen for murmurs. A murmur is a blowing, swooshing sound that occurs with turbulent blood flow in the heart or great vessels. What are the causes of murmur? Velocity of blood increases in cases of exercise or thyrotoxicosis. Viscosity of blood decreases. Example is anemia. Structural defects in the valves, including a narrowed valve or incompetent valve, or unusual openings in the chambers, such as dilated chamber or wall defect. When listening a murmur, note for the following characteristics. Note for the timing. Is it systole, diastole, or all throughout? The loudness. What's the grade? From grade 1 to 6. What's the pitch? Is it high, medium, or low pitch? What's the pattern? Is it crescendo or decrescendo? The quality. Is it musical, blowing or rumbling, the location, where best heard, radiation, the transmission of the murmur, and posture of the patient, the murmur is best heard. This table shows how to grade a murmur. To note that grade 4 murmur is loud with a palpable thrill. Now let's watch this video in auscultating heart sounds.
When auscultating, it's important to know your stethoscope. The diaphragm is better for detecting higher-pitched sounds, such as S1 or S2, the murmurs of aortic and mitral regurgitation, and pericardial friction rubs. The bell is more sensitive to low-pitched sounds, such as S3 or S4, and the murmur of mitral stenosis. When auscultating the heart, remember to correlate your findings with the patient's jugular venous pressure and carotid pulse. You will listen for S1 and S2 in each of the 6 listening areas. In the aortic area, in the right second interspace close to the sternum. In the pulmonic area, in the left second interspace close to the sternum. In the left third interspace, in the tricuspid area, in the left fourth and left fifth interspaces, and in the mitral area at the apex. The auscultation sequence will start with the diaphragm of the stethoscope and progress from the base of the heart, moving from the right second interspace to the left second interspace and down the left sternal border to the apex. Then, with the bell of the stethoscope, we will listen along the lower left sternal border in the left fourth and fifth interspaces. Then we will listen at the apex.
Okay, doctors, and that ends my lecture. Thank you.